I'd like to go ahead and kick off our first talk. It's a distinct pleasure and privilege to invite and introduce Dr. Michael Wagner, Associate Professor at the Fred Hutch Cancer Center in Seattle. Dr. Wagner leads the clinical sarcoma research program at Fred Hutch and has made substantial contributions to treatments of tumors of the heart and blood vessels, especially in leveraging the immune system in treating these rare tumors. So it's a real treat to have you here, Michael. And today he'll be speaking about the systemic therapy of angiosarcoma. Over to you, Michael.
All right, thank you. Can you hear me? My headphones weren't working, so I just took them out. Great. Just give me 1 second. Should share my screen before I do that. All right. So thank you to the organizers for the invitation and Dr. Ravi for the introduction. So I was asked to talk about specifically angiosarcoma of the heart, and specifically also where do we stand in terms of systemic therapies. These are my disclosures. So I'm going to talk about a few different types of therapy. I think there's going to be at least some overlap with Dr. Wang's talk this morning, just because there's such limited data on cardiac angiosarcomas. But first, I'll give a very quick background on what is angiosarcoma, and then talk about some standard cytotoxic chemotherapies that we use for angiosarcoma, both specifically in the heart and then also in general. And then I'll talk a little bit about targeted therapy and immunotherapy. So first, as you all know, angiosarcoma is a cancer of endothelial cells. They're incredibly rare. So angiosarcomas, in terms of all comers, account for less than 3% of all soft tissue sarcomas. About 15% of patients will present with metastatic disease up front. The vast majority first present with localized disease, and they can come up in any part of the body, as you can see on the table here. Angiosarcomas of the heart are a very small subset of all angiosarcomas, where less than 5% of angiosarcomas are primary tumors of the heart itself. And there's a distinction between primary angiosarcomas, ones that just come up, and secondary angiosarcomas, which, at least in the case of cardiac tumors, are most likely to be radiation-induced. Pretty recently, just to try and actually see what is the actual landscape of angiosarcoma in the United States, I, working with a colleague, pulled all of the angiosarcoma cases from the US Cancer Statistics database, where we pulled all of the cases from 2001 to 2017 of angiosarcoma. This database is actually quite nice because it captures almost every single cancer diagnosis in the country. And there were a little over 15,000 patients diagnosed with angiosarcoma over that 17-year period. And you can see from this pie chart that that red little sliver is the primary angiosarcomas of the heart. So that accounts for about 520 cases, and 3.4% of all of the angiosarcomas in this time period were cardiac origin. A lot of studies for angiosarcoma will lump visceral angiosarcomas together. And actually, one of the questions for Dr. Huang was specifically asking, are cardiac tumors different from other visceral tumors? And of course, we don't really know the answer to that yet. But even in those lumped categories, only about 15% of patients are primary cardiac angiosarcomas. In terms of the incidence, it's exceptionally rare. So over this time period, there were about 40 new cases of cardiac angiosarcoma diagnosed per year. Perhaps a slight increase, but that's probably just from population growth. Overall, I'd say it's about roughly the same number diagnosed per year. It comes up in people of all ages, but especially middle-aged, where the median age at diagnosis is 52 years, with a slight male predominance. The prognosis, as you all know, is just abysmal, where the blue curve is the survival of all angiosarcoma cases. We only had survival data for a subset of those 15,000 patients, but this is still almost 2,500 patients. And the red line are patients with primary cardiac tumors, where you can see that barely anyone survives at 5 years, with a few very, very rare exceptions. So how do we treat this? So first I'll start with a case. So this is actually a patient who I'm treating. She's a 37-year-old woman who presented about a year and a half or so ago with shortness of breath to the hospital, was found to have right atrial mass. There was no obvious metastatic disease, although there were some small pulmonary nodules. This is what her CT looked like, where you can see there's that pretty large filling defect in the right side of the heart. She was stabilized and eventually referred to me after a workup that did confirm angiosarcoma. So how do we manage this? There's, of course, very little data to actually say what should be done. One of the larger series that's been published was from the group in Houston, where they looked at a relatively large cohort of patients who presented with primary cardiac tumors and developed an algorithm to say, how should we treat these? Even though it looks pretty complicated, it's actually relatively simple, where essentially if someone is hemodynamically stable, then preference is for systemic chemotherapy. If surgery is needed up front because the patient is not stable or they have significant cardiac dysfunction, then surgery should be done with consideration of chemotherapy afterwards. But our preference is generally for neoadjuvant therapy for a few reasons. One is because if we can actually shrink the tumor, we might be able to facilitate a surgery. And then also, if we can actually see on serial scans what's happening with the tumor, then we know if we're actually helping the patient with chemotherapy. And if we're not, potentially switch to a different therapy. So in this cohort, it was all patients who had primary right-sided cardiac tumors. Most of them were angiosarcomas. And the preference or the choice of chemotherapy in the neoadjuvant setting, if it's given, is doxorubicin ifosfamide. If no response was seen, then patients were switched to gemcitabine and docetaxel. And they actually looked at the patients who had chemotherapy and those who did not. And there was at least a suggestion of improved survival in the group that received chemotherapy, where the median survival went from 9.5 months to 20 months. Of course, those curves are almost overlapping, and it was not statistically significant. But with such small numbers and with such an aggressive tumor, it's hard to truly draw any conclusions, where I think the preference is still to give, at least my preference, is still to give neoadjuvant chemotherapy. But clearly there's room for improvement here. And one thing that I think is important to note is they also looked at patients who had a negative surgical margin versus those who did not. And that actually was significant, where the patients who had a negative surgical margin lived quite a bit longer than those who did not, which poses the question of, can chemotherapy actually help one achieve a negative margin? And I think that alone is probably good reason to give it in the neoadjuvant setting, as long as the patient is stable and can tolerate it. So back to my patient. So she received 6 cycles of doxorubicin and ifosfamide and had actually incredible response radiographically and clinically, where the tumor shrunk to really just a little nub that you can barely see on the CT. And she did go for surgery, and her pathology actually showed no viable tumor cells identified. The tumor bed did extend to the margin, so I think we can argue whether or not that would be considered a positive margin resection. But it was actually very exciting to see such an exceptional, not only radiographic response, but also histological response with no tumor there. Because of the question of the margin, she received adjuvant radiation as well. But then just 4 months later, after finishing the radiation, was back in the hospital with shortness of breath, had this impressive right-sided pleural effusion, and after a long hospitalization and workup, eventually went back to the OR where she had a pleural rind decortication, which confirmed that this was actually metastatic angiosarcoma. So now how do we think about chemotherapy in patients who have metastatic disease? So this is really all extrapolated just from the angiosarcoma literature, where the preferred first-line treatment is either with a taxane or anthracycline-based chemotherapy regimen. Of course, if they got neoadjuvant therapy, then that will factor into the decision-making, just in terms of limitations of what can be given, like how much anthracycline, for example, have they received. And then second-line regimens are generally gemcitabine-based combinations, like gemcitabine and taxotere or docetaxel, or gemcitabine and dacarbazine. And then targeted agents, which I'll talk a little bit more about, can be used, like Votrient or pazopanib is approved for soft tissue sarcomas and can be used for angiosarcoma. The response rates to inhibitors of the VEGF pathway, so especially pazopanib or bevacizumab, are relatively low, with reports or series ranging from about 9% to almost 20% with pazopanib. The reality is probably somewhere in between. And then, of course, immunotherapy is now being more and more used. I have many patients come in and ask about propranolol. There's some anecdotal data supporting propranolol for angiosarcoma. I would argue we need more data before I'd be comfortable regularly recommending it. But it's, in the grand scheme of things, a relatively benign medication considering the other drugs that we use. So sometimes we'll just start it, especially if a patient needs a hypertension medication. And some other drugs that can be tried off-label, especially depending on sequencing results or personalized tailored therapies for any specific patient. The data supporting chemotherapy for angiosarcoma is fairly sparse, where most of what we do is actually guided by case series or small clinical trials. But the response rates for these drugs in these series is actually reported to be quite high, and we see that in clinical practice as well, where especially with taxanes, in particular, if you account for cutaneous angiosarcomas, the response rates are easily more than 50%. The problem is, even if a patient responds to a drug like paclitaxel, the duration of response is fairly short, where the vast majority of patients will progress within a 6 or so month period. So we need more drugs and better drugs to treat this disease. For targeted therapies, and to really have a discussion about targeted therapies, we have to understand the molecular biology of angiosarcomas and really what are we targeting. So there's a little bit of history guiding this, where we now know that angiosarcomas are distinct from just the broader soft tissue sarcomas that we treat, and that you can see visualized in the heat map on the left. And we can further subdivide angiosarcomas into primary tumors, ones that just come up, versus secondary tumors, which in the cardiac angiosarcoma case would generally be radiation-induced. The radiation-associated tumors are generally characterized by MYC amplification. About a quarter of them will have FLT4 amplification, which is the gene that encodes VEGFR3. And a subset small number of patients will have activating mutations in KDR, which is the gene that encodes VEGFR2. Interestingly, those mutations, at least in the lab, are sensitive to inhibitors of the VEGF receptor. So here you can see a Western blot with sorafenib and sunitinib, where the mutations were introduced into endothelial cells, and activation of the receptor or phosphorylation of it was inhibited by addition of the drug. But now we have much better sequencing technology, and through an effort led by Corey Painter called the Angiosarcoma Project, we have good, relatively large data sets looking at what is the molecular profile of angiosarcomas of all primary sites. And in this table, there's of course a lot of mutations. I want to highlight just a couple where in this data set, there were 2 patients with cardiac angiosarcomas included. And kind of interestingly, both of those patients were found to have mutations in genes involved in the VEGF pathway. So one was KDR, so again, that VEGF receptor 2. And then the other patient had an activating mutation in a protein called PLCG1, which is just downstream from VEGFR2. And that mutation was also seen in another sequencing effort out of MD Anderson, where a lot of those originally identified genes were confirmed, and then also loss of function mutations in PTPRB, which is a tyrosine phosphorylase involved in type 2 signaling, were also identified. To talk a little bit more about that activating PLCG1 mutation. So I think the especially interesting thing is that in each of those patients, it's always the same mutation, an R707Q mutation, which is in an autoinhibitory SH2 domain of the protein. And with the presence of that mutation, it essentially removes that autoinhibition and activates the downstream signaling, which in turn leads to increased signaling through the MAP kinase pathway. So we asked the question, how relevant is this actually in human angiosarcoma? And we stained a tissue microarray that included about 60 patients and found that more than half of patients had strong phospho-ERK staining, suggesting that the MAP kinase pathway was activated or active in at least a significant number of these patients who had angiosarcomas. But of course, angiogenic signaling is very complicated. There are many redundant pathways. So, how effective would we really be if we just inhibited MAP kinase signaling? We don't know is the real answer. But I hypothesized that if we can inhibit both MAP kinase signaling along with more upstream inhibition of the VEGF receptor, we might be able to improve the efficacy of the treatment. So we did an in vivo experiment after doing some in vitro experiments where, of course, there are no very good models of angiosarcoma. So we used this transformed endothelial cell line that actually grows pretty aggressively when injected into nude mice. And histologically, the tumors look just like angiosarcoma and treated 4 groups. So one received vehicle or nothing. One group received trametinib alone, a MEK inhibitor. Another group received cediranib, which is a pan-VEGF receptor inhibitor. And then the 4th group received the combination. To do this experiment, we let the tumors grow just a little bit and become established, and then started treatment. And what we found was that, so if you look at the curve on the left, the combination actually pretty dramatically prevented tumor growth compared to either single drug alone, and certainly compared to the untreated tumors. And then when we let those tumors grow a little bit longer, we can see that the combination treatment actually really did delay tumor growth beyond any of those single treatments. So clearly there was something there. But unfortunately, this has not been tested in people yet. And that, I think, just presents one of the challenges of doing clinical trials in such a rare tumor, where even if we take all comers with angiosarcoma, it's a big challenge to actually do a clinical trial. And then if we try and further subdivide that into just cardiac tumors alone, then it becomes essentially impossible to do a large-scale clinical trial. Immunotherapy, of course, is one of the very exciting topics in cancer in general, and especially in angiosarcoma. And that arose from really anecdotal experience where some patients were treated with off-label immunotherapy and actually achieved great responses. There were several trials of immunotherapies in sarcomas, all comers, that did include angiosarcomas. So one of the first studies was a combination of ipilimumab and nivolumab, so anti-CTLA-4 and PD-1 treatment, where 3 patients with angiosarcoma were included. This was a 2-arm study, but all of the patients with angiosarcoma were on the combination arm. One of those 3 had a response. There were no patients with angiosarcoma included on another large study of pembrolizumab. And relatively more recently, a study of TVEC, which is an intratumoral injection with pembrolizumab, also included 3 angiosarcomas, and 2 out of 3 of them actually had a response. And then there's also other case series that, again, report patients responding to immunotherapies here and there. But importantly, most of these patients who are responding have cutaneous angiosarcomas, and especially angiosarcomas of the face or scalp. So back to that angiosarcoma project, another finding in addition to the mutational analyses that they found was that a subset of patients with angiosarcoma actually has a high tumor mutation burden. And that seemed to correlate also with patients who had DNA mutation pattern consistent with UV damage or sun exposure, which makes sense when we're thinking that the patients who are more likely to respond have cutaneous tumors, especially of the face or scalp, just similar to melanoma in terms of the mechanism of oncogenesis. And when we further look into that data, it looks like a lot of those mutations that happen increase the hydrophobicity of the amino acids, which is at least thought to lead to greater immunogenicity. And then when we compare the patients to either just in general the mutation burden of all patients with sarcoma, or to the general mutation burden of patients with melanoma, those patients who have a high TMB are sort of along the same spectrum of patients with melanoma, where we know that immunotherapy is very active, or at least has the potential to be. So with all of that data, and especially the anecdotal reports of patients with really incredible responses to immunotherapy, I was able to take advantage of a pre-existing clinical trial called the DART study, which is a study that's run through SWOG, in the Early Therapeutics and Rare Cancers Committee, which is a multi-cohort prospective study looking at ipilimumab and nivolumab in rare cancers. The study is actually still open for a few rare cancer subtypes, but it included over 50 different diagnoses in what was essentially very small phase 2 studies that were just being done in parallel. And because of the data supporting at least the potential for immunotherapy as an active method of treatment for angiosarcoma, we were able to add an angiosarcoma cohort. Again, the patients were treated with ipilimumab and nivolumab. And what we found was that the response rate is about 25% in angiosarcomas. Of course, only 16 patients were included. But that was actually very encouraging. And if you look at the chart on the left, the purple bars are patients with cutaneous tumors. The green ones had non-cutaneous tumors. And then on the right, you can see a little bit more breakdown by primary just anatomic site, where there was actually one patient with a primary cardiac tumor included on this study. That patient progressed. But there's clearly something there. Just to give an example of what these responses look like. So these are two patients, both with cutaneous tumors of the face or scalp. And you can see pre-treatment on the left and really exceptional responses on the right after treatment. And importantly, oftentimes these responses can actually be durable. At the time of the analysis, 4 of the patients were still on study. I know that at least 2 of the patients are essentially, as best as we can tell, cured without recurrences now several years out. How can we harness this to potentially treat patients with cardiac angiosarcomas is still a question to be answered. But it's something that at least we can think about. And then again, we need to better understand what is the molecular characterization of the patients who are responding, especially. So on that clinical trial, we had molecular data for 8 of the patients. 7 of them had a tumor mutation burden available. Of the responding patients, we had that data for 2 of them. 1 of them actually had a high TMB. The other had what was termed as an intermediate mutation burden, just based on the platform that the sequencing was done. All of the patients had some sort of deleterious genomic alterations identified, but none of them overlapped, where they all seemed to have different molecular profiles. Interestingly, one of the patients actually who was included on this study, this was a patient with a radiation associated breast tumor, had an NTRK fusion, and 2 of the patients had high PD-L1 staining. We only had data for PD-L1 staining on 3 of them. But from other retrospective case series, it does seem like angiosarcomas have a relatively high expression of PD-L1. This is a chart defining those molecular alterations in a bit more detail. And I'm showing this really just to highlight that we did have the molecular data for one of those patients, or for the one patient with a primary cardiac tumor. This patient had a low mutation burden, did not have PD-L1 staining done, so we don't know what that status was. And then on the sequencing, there was a BRAF mutation, which was kind of interesting, not V600E, which is the more common one that you see in melanoma, but potentially that might be relevant in terms of trying to personalize treatment, where having just BRAF mutations might suggest that inhibiting that pathway, which is also involved in the MAP kinase signaling pathway, might be a potential way to treat this disease. There is a study that is currently ongoing. It actually just finished accruing, actually about a week or 2 ago, of asking the question, can we combine chemotherapy with immunotherapy for angiosarcoma in upfront treatment? At least as far as this study is concerned, only patients with unresectable or metastatic disease were eligible, but essentially it's randomizing patients to either just receive paclitaxel alone or paclitaxel plus nivolumab for patients who are taxane naive. There was a separate arm of this study, which is almost like a completely separate study, for patients who had been pretreated with taxanes. They all received a combination of cabozantinib, which is another tyrosine kinase inhibitor that inhibits a number of different proteins, combined with nivolumab. And again, this is fully accrued, and we're expecting at least some early signal of results at some point this year. All sites of angiosarcoma primary tumors were eligible for this study, so I don't know how many cardiac patients were actually enrolled. I know at least 1 because I put them on, but we'll just have to see what the results ultimately show. So to summarize, cardiac angiosarcomas are exceptionally rare and very aggressive tumors. Chemotherapy does seem to have a modest benefit, and as you saw even from the patient that I treated, can have a pretty dramatic response in terms of both shrinkage of the tumor and even histological responses. But those responses, unfortunately, just really don't seem to last for a very long time. So we need better drugs. In select patients, targeted therapies might be beneficial. I think sequencing these patients is important because that's the only way to actually identify what mutations they might have. And just like with all cancers, personalized therapy and really molecularly targeting or choosing the treatment for the alterations that are specifically in the patient, I think is going to be important. And then immunotherapy has been very exciting, especially for angiosarcoma. But the role in cardiac angiosarcoma right now is still unclear, and we just need more data is really the bottom line. So I'm happy to take questions. I do have clinic, so I can take questions now, but I'm going to have to go in like 30 minutes or so.
Michael, thank you for that excellent talk. Since you're going to have to break off, there are a couple of questions that have popped up on the chat. The first question is from Dr. Razak, asking about the impressive responses of neoadjuvant AIM. They're relatively short-lived. So is there a role for adjuvant or maintenance treatment, post either to prolong that stability that is achieved using AIM? For example, your patient had an excellent response. How do you really try to maintain it and move forwards from there?
Yeah, so excellent question. I think that's in part the big question in all of sarcoma. So for patients who don't have upfront chemotherapy with cardiac angiosarcomas, I do essentially in all cases, as long as they're able to tolerate it, recommend adjuvant chemotherapy, just because this is such an aggressive disease where for cardiac tumor specifically, we know it's going to come back. It's more a question of when, not if. And if you go back to that survival curve, at 5 years, virtually nobody is alive. And that's looking at almost every, or probably actually every cardiac angiosarcoma that was diagnosed in this country over the past 17 years, going up to 2017. So I at least recommend adjuvant chemotherapy, and I generally will recommend doxorubicin and ifosfamide for patients who have good responses. Is there something that we can do for maintenance? Unfortunately, these are just really toxic chemotherapies, and we can only give so much. I wish we could just continue it forever, but we just can't. So, there's, what could we do? Could we go to a different chemotherapy like gemcitabine and taxotere and just give them serially? That, I think is an option, but generally, after getting 6 cycles of AIM, you can't just start Gemtax right away. So I would generally wait until there's a recurrence and then start chemotherapy when you can actually see what it's doing. Is it actually shrinking the tumor or not? But it's just a tough disease, really.
Thanks, Michael. I have a question from RJ asking about the role of hyperbaric oxygen as a treatment adjunct in the setting that VEGF may be an important player in at least a subset of these particular patients.
That's an interesting question. I don't know the answer, is really the only answer I can give. Yeah, I honestly don't know. But if there is data supporting that, I'd be very curious to see it.
RJ, do you have any comments? Is there any preliminary data that you want to discuss there? I'm not aware of anything in this particular space either. So if you have any, please do speak up.
No, it was just a question that I had about them. Most of the ones that we see in the heart are on the right side, hypoxic tissue or hypoxic environment, and VEGF, one of the strongest things in the heart, I'm a cardiac surgeon, is ischemia. And so hypoxia seems to play a role in ischemia and getting new blood vessels in. We're using anti-VEGF medication. I just wondered if anybody's looked at hyperbaric oxygen. It's something I sort of thought of.
Thanks, RJ. I have another question from Dr. Jones from Royal Marsden. Do you think we have sufficient data to use checkpoint inhibitors routinely in visceral angiosarcoma, Michael?
Do we have sufficient data? No, but do I do it? Yes. I mean, certainly there are patients with visceral angiosarcomas who responded to immunotherapy. So on that DART study, there was one patient who technically did not have a confirmed response, but that was actually more because of an issue at the site where the patient was treated. One of the follow-up scans excluded the full CT of the chest, abdomen, pelvis. So then when they got the next scan, and there was progression, we couldn't confirm that the patient actually had a response. That was a patient with a liver primary angiosarcoma where there was tumor reduction, was not confirmed on the next scan because of that problem. But then there was growth afterwards. So, and then also the group at Memorial Sloan Kettering and Dr. Ravi, as I'm sure many patients who have responded to immunotherapy with visceral angiosarcomas. Even for cardiac angiosarcoma, there was a patient who I saw a number of years ago, actually very shortly after I came to Seattle, who was treated elsewhere, but had a primary cardiac angiosarcoma with obvious lung metastases, had radiation to the primary cardiac tumor, and the lung metastases all shrank. It was fascinating. And I wanted to include pictures of that, but when we switched medical record systems, all of that data was lost. So I couldn't put it in this talk. But it raised at least the question of some sort of abscopal effect in a primary cardiac tumor. And yeah, I do think that there's probably some role for immunotherapy. It's just not well defined right now. And, my hope actually is that that Alliance trial will help give some guidance, because that's actually a pretty big study where I think the total accrual is something like 90 patients across that whole study. And, just from looking at the enrollment on the DART study, there were a lot of patients with visceral tumors enrolled there. And I suspect it will be at least a significant amount, I don't know how many, on the Alliance trial. And then from doing the subgroup analyses, I think we'll be able to better answer that question. But really right now, we don't have good enough data, but there's enough anecdotally, and this is just such a bad disease that I generally will at some point recommend it to patients.
Michael, thanks for that. I completely agree with you. Most of us do and use checkpoint inhibition at some point for these visceral patients as well. My question for you is, do you feel like for these rapidly growing angiosarcomas, also in that visceral subset, including angios and other visceral sites, perhaps the checkpoint inhibition it should be introduced following that cytotoxic chemotherapy to slow things down? Again, tying it again with Albie's question about maintaining the good gains from the systemic therapy. Is that a more appropriate place to place checkpoint inhibitors? So would love to know your thoughts on that.
Yeah, I mean, also an excellent question. We just don't have data to truly guide doing that. If I knew the molecular characterization of the tumor, like if someone I thought was a high likelihood of having a response, so I'd probably be more likely to do something like that in someone with a cutaneous tumor, especially a scalp or face tumor, where they're just more likely to actually benefit from the immunotherapy. For a visceral tumor, depending on the specific situation and really just kind of what the patient wants and is pushing for, I'd probably be more reluctant just because of the potential for immune toxicity with an uncertain benefit. But if a patient were to come to me and very strongly want to do something like that, where we give chemotherapy up front just because, sorry, the lights just turned off in my office, but if we had to give chemotherapy up front because it's growing quickly, and then we were able to get a checkpoint inhibitor, just knowing that this is an incredibly aggressive disease and it takes time also for the immunotherapies to even have some sort of benefit, to start it earlier on is something that, intuitively, at least it makes sense, but is that the right thing to do? I don't know.